Hello and welcome to our online course on improving clinic operations, observing and documenting patient visits. My name is Patricia Blackburn and I'm a Vice President at Cardia and will be one of the facilitators of today's course.
And I'm Johanna Rosenthal. I'll be joining Pat as a co-facilitator on this course. On behalf of the California Primary Care Association and Cardia, we are pleased that you have selected this module to support your professional development.
Cardia is a non-profit, mission-driven organization with a principled team of committed and passionate staff. We have dedicated our careers to helping health and human services providers offer their best to their patients.
You see here on the slide the official mission of the organization. You may be aware that CPCA is offering this training as a part of their Patient-Centered Health Home Recognition Program. This initiative is for its member clinics to support their efforts to achieve Level 3 standards of National Committee for Quality Assurance Recognition. CPCA has made a commitment to support every member community health center to become a patient-centered health home. For more information, go to CPCA's website listed here. There are several handouts of the material we plan to cover. It may be helpful to download and print those to refer to as you go through this course. If you haven't done so already, we'd suggest you stop this video and do so at this time. We'll let you know when it's time to refer to them.
There are 3 objectives that will give you a sense of what we're going to cover in this module. These are the things we hope you'll be able to do as a result of taking this course. First, we hope you'll be able to describe how observing and documenting patient visits is part of a quality improvement process. By the end of the course, you should be able to implement the process to observe and document patient visits at your own site. We'll also describe how you compile and analyze your results so that you'll be able to do that with the results you get from the observations and documentation of patient visits that you complete. We'll start with our first objective to see where it fits with quality improvement and how that fits with the NCQA standards for patient-centered health homes. NCQA, as you probably know, has published standards for patient-centered health homes that include 6 standards and numerous elements under each standard. This course focuses on Standard 6, which is Measure and Improve Performance. Element A under Standard 6 is listed on the slide. You can see that it's to measure performance of preventive care, chronic or acute care, utilization that affects cost, and vulnerable populations. Element B under NCQA Standard 6 is Measure Patient and Family Experience. Sites need to conduct surveys to evaluate patient and family experience with access, communication, coordination, whole person care, and self-management. They need to be utilizing the CAHPS survey tool, obtaining feedback from vulnerable populations, and collecting some qualitative feedback from patients and families. This particular element was discussed in a fair amount of detail in the module on patient satisfaction assessment. Element C in NCQA Standard 6 is Implement Continuous Quality Improvement. This is a must-pass element, meaning you must score at least 50% or higher on all aspects of Element C and on any other must-pass elements to achieve PCHH recognition. This element requires that sites use an ongoing quality improvement process to improve 3 measures from Element A, improve performance on 1 measure from Element B, address at least 1 disparity in care for vulnerable populations, and involve patients and families in QI activities. The process we're discussing today qualifies to improve performance on Element B and potentially on improving disparity in care. Element D of NCQA Standard 6 is Demonstrate Continuous Quality Improvement. This involves ongoing monitoring of the effectiveness of your site's improvement process. Element E relates to reporting performance, which means that you need to share the performance data with clinicians, staff, patients, and the public. So how do we define quality? First, it relates to the degree of excellence when measured against other similar things, in this case health systems. Some of you may have heard patients say, "I now have a job with insurance, so I'll be going to a real doctor." Your services, particularly with the Affordable Care Act, will be measured against other healthcare providers, so quality is very important. Quality means meeting or exceeding expectations. For example, many health centers are working very hard at reducing the wait time during a clinic visit. Finally, quality is the degree to which the desired outcome improves. Knowing your desired outcome is obviously critical. Your goal could be increasing access to those who need your services. But whatever the goal is, identifying it and measuring your success is key. So that's quality. What is improvement? You see here the definition of improvement. It includes betterment and advancement, enhancement or sweetening, fixing, repairing, or mending, upgrading. The key again is to be able to identify what you want to improve and then be able to document that improvement has occurred. QI, or quality improvement, and QA, quality assurance, are sometimes confused. Let's spend a moment to clarify the differences. They are connected and both are very important but different. You can see from this slide the comparison of the two. The biggest difference is that QI is driven by staff and patients, whereas QA is a management activity. Also, QI focuses on systems and processes, whereas QA tends to focus more on individuals. Most of you probably already have quality improvement plans and activities. Our focus today is on collecting baseline data in order to identify if you need to improve the clinic processes and patient and staff flow or not, and if so, what areas need improvement. Just as a reminder, let's look at the key components of a QI plan. So some of the components are that leadership involvement is critical, which means that the mission, goals, and objectives of the site support QI, and resources are provided for QI activities. QI teams, and they can vary, are empowered to do the work. They have the assignment, the timeline, and the time to do the work. And finally, they're customer focused. Whatever we're looking at, be it issues related to clinical conditions or clinic processes and patient flow, the focus should always be on the patient. QI involves data collection. You'll need tools, indicators, and benchmarks that are clearly defined so you know what to look at as a baseline and what to do on an ongoing basis to see if your improvements did what you'd hoped. Process relates to how you go about implementing improvements. We have one process to recommend that you may already be familiar with called the PDSA model. The plan needs to be continuous, meaning it's an activity where you look at different indicators or processes on an ongoing basis. There are some basic steps in conducting QI activities. First, you set the aims. What are you trying to accomplish? Second, you need to establish measures. How will you know that a change is an improvement? The course today on observing and documenting patient visits is really to help you set your aims and define what you're trying to improve based on the data you collect. This process also identifies the areas you'll want to measure to see if the change improves patient quality. The other steps in this QI process are things you'll do after collecting patient flow data and other data to get baseline information and identify areas needing improvement. Those steps involve selecting changes you want to make to improve the issues you identify at baseline that need improvement. Finally, you need to test those changes. We recommend the PDSA model. Many of you may know the PDSA model, which is a rapid testing process where on a small scale you plan what you're going to change, you do or implement the change, you study what you've changed to see if it resulted in the improvement you'd hoped, and you act on what you learned to modify the change and repeat the PDSA testing until you get the result you're looking for. A review of potential changes you can make to improve patient flow will be discussed in a final module on strategies for improving clinic operations. We'll discuss the PDSA model in more detail in that module as well. We'd like you to pause the video for a moment to think about and note what you already suspect are problems with your patient flow. Just quickly jot down all the things you've observed or think are negatively impacting the process. One example might be high no-show rates. There are many others. So why don't you stop now and think about what is going on at your site that may be impacting your patient flow. Hopefully you came up with some issues that you think are affecting the flow of patients and the operation of the clinic. We've asked that same question of staff and patients in a number of sites as well as observed clinic operations, and here are some of the common things we see or hear. One is patient access, which relates to whether a patient can get through on the phones, how busy the phones are, and whether they're manageable for staff. Hours of operation is another issue. How convenient are they for patients? And then finally, appointment availability. Do patients have lots of choices of appointment times, or are those limited? Patients may be waiting too long for services once they arrive. And then there's throughput, which relates to the number of patients that are seen by the staff, space, and facilities that are available at that particular time. And is that adequate to meet the patient demand? And for many sites, throughput can impact revenues. The more efficiently patients are seen, the more patients that can be seen, and the more revenue generated. Some additional common issues include staff ability to do the job they're assigned efficiently, which can impact the flow, and the structure of systems and processes may not support staff to do the right things efficiently. Stress and pressure when those processes are not working well can definitely result in staff dissatisfaction. The layout of the site may also be an issue. Are staff or patients having to walk far to provide or receive services? How easy is communication between staff? Is it easy for the back office to know when a patient is ready to go into the room? Does the clinician know when the patient is ready? And are there enough exam rooms to accommodate the number of clients and clinicians that you have? We've just reviewed some common patient flow concerns that we've seen in the field and that hopefully you identified as issues that you suspect are impacting the flow at your site. In order to get accurate data on what's negatively as well as positively impacting your site's patient flow, the rest of the course will describe a patient flow observation process. We'll give you information on what and how to observe the clinic processes and how to document what you see. The patient flow observation process we're about to describe is an adaptation of the Coleman and Associates patient tracking process. We're going to be observing patient visits, which means you will be making careful observation of a patient throughout his or her visit from the moment of arrival to the moment of departure. Not only will you be closely watching the patient, but you'll also be noticing what else is going on in the clinic that could be affecting the flow or wait time for that particular patient. The approach we're going to discuss suggests that staff be involved in this observation process. This is not absolutely mandatory, but it's a real advantage because it gives that staff the opportunity to observe their clinic flow from a different vantage point. Because rather than being immersed in one's own job function and daily responsibilities, the observer gets to be a fly on the wall and potentially gain some new insights from this new perspective. Having your own staff observe also helps to create staff buy-in. If they make their own observations about what's working and what's not, they're more likely to support the changes necessary to make improvements. Surprisingly, past experience has shown that observing as few as 12 to 15 typical patient visits paints a fairly clear picture of how your site is doing in terms of patient flow.
You may find that it's helpful to make the following points to your staff before beginning the patient flow observations. Remind them what the purpose is. Here's an example of what you could say. Our objective is to thoroughly understand all the work necessary in a patient visit to see if it can be made faster, simpler, and better for patients and staff. We will be observing patient visits, which means that we'll be directly recording all steps necessary to complete a patient visit. As the observers watch you work, they'll probably ask you some questions to make sure they really understand what it is you do, since not all staff here are familiar with details of all job functions. Please be patient with them. Also understand that we are not evaluating people or judging performance in any way, shape, or form. We are looking only at systems and processes and ways to improve patient flow and staffing configurations.
It is important that all staff know that their input is valued. So be sure to encourage staff to share any insights, suggestions, or ideas that they have as your site embarks on this work. Johanna is now going to tell you about the tool that you'll use to make your observations.
The method you'll use to observe and document patient visits is quite simple. The only tools you'll need are a clipboard, a pen or pencil, and the patient flow form, which we asked you to download at the beginning of the course. You'll use one form for each patient that you observe. As you can see, the top of the form gives you space to write today's date, your name as the observer, the patient's appointment time and actual arrival time, the payer source, the visit type, the name of the provider, and the patient's gender and age. Each of these fields can potentially provide you with clues as to why the visit went as slowly or as efficiently as it did. For example, you might notice that patients who have a particular payer source take longer to get to the exam room than others, perhaps because of additional paperwork needed. As you continue down the form and look at the column headings, you'll see step, time, stop locations, staff contact time or wait time, and observations. The step column just allows you to refer to a particular step number when you're analyzing results and discussing the patient flow form with your team. Stop/locations is the place to indicate where the patient is. Are they in the waiting room, the exam room, checkout, etc.? The next column is the staff contact time or wait time, depending on the circumstance. If the patient is in contact with a staff person, the job title of that staff person would be written here. If the patient is not with a staff person but waiting, a triangle would be drawn here as the symbol to represent waiting. We'll talk about other symbols shortly. And lastly, the final column, called Observations, is where you will write down everything you're seeing. The goal is to write enough detail so someone who wasn't there will be able to clearly understand what occurred during that patient's visit. Each visit will likely take many steps, so you'll end up using at least a couple of pages, depending on how long the visit took. At the bottom of the patient flow form is a table called Visit Statistics, where you'll summarize your results. Here you can see the variables you'll be looking at and analyzing. The first variable is cycle time, which is discussed in more detail in a different module titled Improving Clinic Operations, the Importance of Data Collection. Cycle time is the length of time, expressed in minutes, that your patient was under your roof. You can easily calculate this by looking at arrival time at the top of your form or the time noted in the first step or row of your patient flow form. Then look at the last row on your sheet, which will be the time the patient departed. The next variable is number of stops. How many different places did the patient have to move to during the visit? A typical visit would probably have the patient beginning in the waiting room, then perhaps moving to a registration area, then an area where vitals are taken, then to an exam room, and then to checkout. If that were the case, this patient visit would have 5 stops. Handoffs refer to the number of times the patient was passed along to another staff person. The staff person who makes the first contact with the patient is not counted, since no one handed off the patient to him or her. So, if the patient is first greeted by the front desk, then called back by a medical assistant, then seen by the nurse practitioner, then seen by the medical assistant again, then checked out by the front desk person, the number of handoffs would be 4. Remember, the first person is not counted. The front desk person handed the patient off to the medical assistant, who handed her off to the nurse practitioner, who handed her back to the medical assistant, who handed her back to the front desk person. Theoretically, keeping the number of handoffs to a minimum is more efficient and better service. The patient doesn't have to retell her story to each person, and rapport doesn't have to be reestablished each time. However, this goal needs to be balanced by the necessary different roles that each staff person plays. Handoffs are just something to keep in mind as you look at your current systems and flow. Wait time means any time when the patient was left alone or not in contact with a staff person. This is considered wasted time. No service is being provided to the patient and she or he is left waiting. When results are analyzed, this variable is expressed in minutes as well as a percentage of the total visit time. Staff contact time, then, of course, means just the opposite. This is the time that the patient is in contact and being served by a staff person. This is also expressed in minutes and as a percentage of the total visit time. Patient-provider time, or PPT, refers to the length of time the patient spends with the provider. This will be a subset of staff contact time, but it's important to look at how much time the patient spent with the person that they really came to see. RN or MA time is the number of minutes the patient spends with a nurse or medical assistant, either having vitals taken or receiving some form of education or counseling or instructions. This again would be another subset of staff contact time. Waiting room time is self-explanatory. How long did your patient spend in the waiting room? Be sure to include any returns to the waiting room, not just the initial wait. You can decide if you want to distinguish the time the patient spent doing paperwork or not as a subset of waiting room time. And lastly, wait time in the exam room. Moving your patients out of the waiting room doesn't always make a lot of sense if they are then going to feel stuck in the exam room for some indeterminate time, often half undressed. So this is a very important variable to look at. I now want to draw your attention to all of the symbols or shapes on the left side of the visit statistics table. These are symbols that you will draw on each step of your forms when you're ready to analyze your observations. They provide a visual for you to more easily see which steps had the patient waiting and which steps involved contact between patient and staff. You can also easily count how many times the patient moved to a new location within the clinic. I'll explain what each of the symbols mean now, but then we'll show you how they're used on the form when we show the form in practice during our case example. Rectangles represent locations, triangles represent waiting time, and circles represent staff contact time. So as you can see, you'll be looking at all of the rectangles on your form when you count number of stops. You'll look at triangles when you calculate all wait time. And you'll be looking at circles, or ovals, when you calculate the number of handoffs and all staff contact time.
Now that you're at least somewhat familiar with the form, let's talk about how you actually conduct patient flow observations. When you first begin your patient flow observations, it can be helpful to work with pairs using the same patient flow form. One person times and notes the patient's progress through the visit. The other person swims upstream to discover the reasons for delays and problems. Depending on how busy your clinic is, you can continue to work in pairs this way, or decide you can manage the observations on your own. Make sure that you synchronize watches if working with a partner. Synchronize clinic clocks if you're using clocks instead of watches. Observe typical visits, avoiding those that will clearly be very short or very long. Observations begin when the patient enters the facility, not necessarily when they check in or when the front desk calls their name. If your site has a waiting line to check in, try to capture arrival time, not check-in time. Observations end when the patient leaves the facility. Write down the time, location, and who is in contact with the patient during each step. You'll see on the slide that we've included the name of the staff person in addition to the position because there are two people serving the patient at the same time. Be vigilant observers. For example, notice how many times the patient has to walk back and forth to the front desk, and document did the provider ever have to leave the exam room or why. Make sure you don't miss those quick ins and outs. Wait time does include the time this patient spends filling out paperwork, so do try to capture paperwork time as a subset of the total waiting room time. During patient waiting time, explore the reasons for the delay, but only in ways that don't alienate staff or change the flow. You don't want to appear judgmental or critical, and if you need to inquire about the delay, do so as quickly and inconspicuously as possible. Do not interfere with patient visits in any way unless the patient's health or safety are at risk. You are there only as an observer and not as an additional staff person providing service. Your interference will influence the result of your analysis. Do not enter exam rooms with patients. Making a copy of the patient's encounter form at the end of the visit can prove to be useful for filling in any missing information about the visit that wasn't captured on the patient flow form. If you decide to do this, be sure to delete the patient's last name to protect the patient's privacy. Here are some additional tips to make sure that your documentation is as useful as it can be. Most of these tips are based on our experience reviewing past patient flow forms that could have been more complete. Even though the instructions say to look for the reasons for the delay by swimming upstream, it's very easy to just get caught up in watching the patient. Don't forget to explore why a backup or a bottleneck is occurring. Possible reasons for a backup may include there were a lot of walk-in patients preceding the patient you're observing. A preceding routine visit is taking an unusually long time, but why? Does the patient have unexpected needs, which may be hard to determine during your observations, or are there systems issues that are causing the extended appointment? Were exam rooms well stocked? Did the provider have to leave the room for something? Are the providers ever waiting for the patient or for the medical assistant to finish with the patient, or are the medical assistants waiting for the provider? Whatever the case, write it down. Be sure to document every time the patient is in contact with a staff person. If it's not documented, we can only assume that the patient is alone and it will be calculated as waiting time. If two staff are in contact with a patient, be sure to note when each staff person leaves. Here's an example of documentation that had some missing information. The MA provides counseling in the exam room. The provider enters and performs the exam. The provider exits the exam room to chart, and the patient gets dressed and also exits the exam room, but we don't know when the MA left. Be sure to document the location of every step. For example, rather than writing vitals taken, note if they were taken in the same room as the exam, in the hallway, in a screening room, or in a counseling room. You're trying to get a sense of how often the patient has to move around the clinic to different stations. And we want to reiterate this point one more time because it can be easy to miss. Document interruptions or the provider going in and out of a room. For example, provider left the room for 2 minutes to retrieve educational materials. Note how not only was the action documented, but the reason for it. Though we defined cycle time earlier, as well as in the other modules, we want to clarify that cycle time ends when the patient leaves your clinic. It does not include post-visit charting. You may still document the time it takes to do post-visit charting, but it should not be included in the patient's cycle time.
So now let's assume that you've conducted your 10 to 12 patient flow observations and you're ready to look at them. The first thing you'll need to do is add your symbols and number of minutes for each step. Let's look at this sample form together. You can see that a rectangle has been placed around each new location. A triangle has been drawn each time the patient is waiting or is not in contact with staff, and a circle is drawn around each staff person. As you look at the time noted for each step, calculate the number of minutes for each step and include it in the staff contact time or wait time column. Double-check your numbers by making sure that the sum of all the minutes in that column equal your cycle time. This slide is just representing page 1 of this patient flow form, and we've drawn a blue circle around that column. Once your patient flow form has been completely filled out, you can add up the minutes in the appropriate steps to calculate the variables in the visit statistics table at the end of the form.
Now we're going to go over a case study that walks you through the entire process. Marissa arrives for her 10 a.m. appointment 8 minutes late. The clinic parking lot was already filled, so she had to look for street parking. Feeling a little frazzled, Marissa signs in at the front desk and takes a seat. She notices other patients being called up to the front desk ahead of her. She's eventually called up to the front desk and handed paperwork to fill out. This is Marissa's first time at the clinic, so she has quite a few forms to fill out. She brings all of the paperwork to the front desk staff and returns to her seat again. After a period of time, the front desk staff person calls her up to determine eligibility and collect her copay. Marissa returns to her seat one more time. The provider reviews the record, learns that Marissa has had some difficulty urinating, and informs a medical assistant that Marissa should leave a urine sample before the provider sees her. Unaware of this, another medical assistant, in an effort to keep patients moving along, takes Marissa to an exam room. She takes vitals, confirms that this is an initial physical exam visit, documents this in the computer, and sets up the computer for the provider. The first medical assistant knocks on the door to tell them that Marissa needs to leave the room to give a urine sample. The provider comes to the exam room, but Marissa isn't there, so she goes to make a return phone call. Marissa returns to the room after leaving a urine sample. She waits for at least 10 minutes for the provider. The provider returns to the room and takes a detailed history, conducts a physical exam, and discusses a plan for care with Marissa. The provider reaches for the list of referrals, but the bin is empty. The provider leaves the room to look for more referral sheets, but as soon as she emerges from the exam room, a medical assistant says she has a very quick question she needs to ask. The quick question ends up taking longer than expected. In the meantime, Marissa has been sitting in the exam room wearing only a paper dressing gown and is worrying about her meter expiring. The provider finally returns to the room, apologizes for the delay, and hands her the referral sheet. The provider tells her to make a follow-up appointment in 1 month and leaves the room. After dressing, Marissa goes to the checkout window and waits for one other patient to check out first. When it's finally her turn to check out, the checkout person has to answer the phone. Marissa is so worried about her meter running out that she decides to call to make her follow-up appointment rather than wait for the checkout person to get off the phone. Marissa exits the facility. The provider finishes documenting the visit in Marissa's electronic record.
Now that you've heard about Marissas Visit, let's look at the patient flow form that was filled out. Marissa's appointment was at Health First Clinic, and Gabriella was the staff observer. Gabriella sees Marissa arrive at 10:08 in the morning and notices that the appointment system has her scheduled for 10 o'clock. The schedule also says that she's here for an initial physical exam, so she's a new patient. Gabriella cannot tell what kind of insurance coverage, if any, she has at this point. She's scheduled to see the nurse practitioner, Linda, and she's a 27-year-old female. Notice that Gabriella has written down what Marissa does upon arrival, as well as how many other patients are waiting. Her destination is the front desk, so Gabriella puts that down for Marissa's location. There is no interaction with staff at this point. Step 2 shows that Marissa is settled into the waiting room, but Gabriella also notes that 2 other patients are called ahead of her to receive paperwork. She documents that she asked the front desk for the reason and then writes their response. This is all important information to have as you consider the systems you currently have in place. In steps 3, 4, and 5, Marissa receives paperwork, fills it out, and returns it. It takes 3 steps to illustrate this because we want to clearly show the amount of back and forth that Marissa is experiencing during her wait. By this 5th step, she has gone to the front desk 3 times. In step 6, Gabriella is documenting how long Marissa is waiting without doing anything else. She is done with her paperwork. Gabriella also takes this time to see what is happening in the rest of the clinic that could be causing the wait. The front desk staff are busy with paperwork and phones, and in the back, 1 exam room is open, 2 are full, and 1 provider is charting. Steps 7 and 8 show that Marissa is finally called to the front desk to discuss insurance and her copay, and then returns to her seat for a few minutes. Gabriella has noticed that the provider is reviewing her paperwork in the back and tells a medical assistant, Anne, to make sure Marissa collects a urine sample before she sees her. In step 9, notice that 2 medical assistants are documented. M.A. Sue calls Marissa to the exam room to take vitals and confirm the reason for the visit, but M.A. Anne has to interrupt to tell M.A. Sue that Marissa needs to leave a urine sample. Gabriella has noted how much time each M.A. has spent with her. During step 10, Gabriella has documented that Marissa has left for the restroom just as the provider is ready to see her. Not wanting to wait, the provider leaves to make a phone call. Step 11 shows Marissa's long wait in the exam room, but also shows that Gabriella has observed that the provider is still on the phone. Jumping to step 13, Gabriella has noted the reason why the provider had to leave the room and what further prevented her from returning promptly, a question from another MA. And moving along to step 16, Gabriella has written down all of the reasons why Marissa had to wait 5 minutes to make her follow-up appointment and check out. 1 patient is ahead of her, and then the checkout person must answer the phone. And finally, step 17 shows the time that Marissa leaves the facility without making her follow-up appointment. Once a patient leaves, you can start the process again with a new patient. It's sometimes possible to observe 2 patients at the same time if the clinic is not too busy and you think you can accurately keep track of what's going on. After you have finished observing your patient, or after you have finished observing all 10 to 12 patients, you can go back to your patient flow forms and apply the symbols and number of minutes to each step. Returning to Marissa's visit, Gabriella has drawn a rectangle around each change in location. Even though the front desk and the waiting room are likely in the same room, Gabriella chose to count them as different locations to draw our attention to the number of times Marissa had to go back and forth between the front desk and her seat in the waiting room. You can see that whenever Marissa was not in contact with a staff person and therefore waiting, a triangle is placed in the 4th column. The number of minutes is also noted inside the triangle. Make sure that the number of minutes in the triangle added to the arrival time in that step equals the beginning time of the next step. For example, if you look at step 2, Marissa began waiting at 10:09. She waited for 6 minutes, and so the next step begins at 10:15. In step 3, she is in contact with the front desk staff person, and a circle is drawn around that job title in column 4, along with the number of minutes. Circles represent staff contact time. Notice that in step 10, though Marissa does not have any staff contact while she's in the restroom collecting her urine sample, we still put a circle around the number of minutes because specimen collection is just as valuable and important as staff contact time. Remember that all circles are staff contact time and restroom time in this case, while triangles represent wait time. The last step to completing your patient flow form is filling out the visit statistics at the end of the form. Again, using Marissa's visit as our example, if you look at Marissa's arrival time of 10:08 and her departure time of 11:23, her cycle time, meaning the total number of minutes she was at your facility, was 75 minutes. The number of stops is the number of locations where the patient spent time during her visit. So for Marissa, it is 11 stops. As you may recall, handoffs is the number of times the patient moves from one staff person to another. Again, you do not count the first person she is in contact with, since no one has handed the patient off to that person. During Marissa's visit, the front desk staff handed her off to M.A. Sue, who handed her off to the provider, who handed her off to the checkout person, even though she didn't have time to wait to actually be checked out. There were still 3 handoffs during her visit. You can easily find the wait time by adding up all of the numbers in the triangles. Triangles equal waiting. We ask that you calculate the number of minutes, but also express it as a percentage of the cycle time. So in other words, we want you to look at what percentage of the entire visit was wait time. And you can easily find the staff contact time by adding up all of the numbers in the circles. This should also be expressed as a percentage, just like wait time. Make sure that your wait time and staff contact time minutes add up to the cycle time, and that the percentages for each add up to 100%. If not, there is an error in your calculations. Patient-provider time is self-explanatory. It is just the time that the provider spent with the patient, so it will be a subset of staff contact time, and also shown in minutes and as a percentage. The same can be said about RN or medical assistant time. We're suggesting that you include the time they spent with the patient taking vitals, providing education or counseling, again as minutes and as a percentage of the visit. The last 3 fields to fill out are also quite clear. You will be looking at triangles, and specifically time spent in the waiting room, time spent filling out paperwork as a subset, and then time spent in the exam room without any staff person.
As you look at these visit statistics and the patient flow form observations for Marissas Visit, what would you think if she were a patient at your clinic? Would you be satisfied with the cycle time, or the number of stops and handoffs, or the time she spent waiting versus having staff contact? If you're not satisfied, what might you want to address or change about this visit? Please pause the module to think about your answers to these questions. You may also hit the back button to review the patient flow form, observations, and visit statistics again. Here are some of the thoughts that we had about the visit. Marissa spent a lot of time going back and forth between the front desk and waiting room. How could this have been minimized? Is staffing adequate? Is paperwork organized and ready to go for new patients? Could paperwork have been sent to Marissa earlier or have been made available online? Could the need for a urine sample have been determined earlier so that Marissa was in the exam room and not in the restroom when the provider was ready to see her? If the exam room had been stocked with all needed materials and forms, the provider would not have needed to leave and thereby get distracted by another MA. Are staff cross-trained to do front desk and checkout? Is staffing adequate at the front desk and checkout? Were your thoughts similar or different than what I just mentioned above? These are the kinds of issues the patient flow observation process allows you to look at and think about carefully. Now what? You have your 10 to 12 patient flow forms, all minutes and symbols have been added, and all visit statistics have been calculated.
We'd now like to review the Patient Flow Dashboard, which is an Excel spreadsheet tool that allows you to look at all of your patient form data in summary form. It also allows you to calculate averages and gives you a snapshot of your visits. This was also one of the files we asked you to download earlier. You'll see that the first tab in the document is a blank form for you to use, and the second tab or sheet is the same sample dashboard that you see on the screen, so you can look more closely at the calculations we'll be discussing. You'll see all of your variables and data collection elements across the top as your column headers. You'll see the assigned patient number, visit type, appointment time, arrival and departure times, cycle time, waiting room time, MA time, wait time in the exam room, total wait time, total staff contact time, patient provider time, and stops and handoffs, as well as columns for the percentages we discussed before. The last comments column is a place for you to write down explanations or anything you think that would be useful for someone to know about the visit. Each row represents an individual patient's visit and contains the data from each of the patient flow forms. You can use the simple sum formula in the toolbar above to add up each column, and you can see that there is a row of totals at the bottom. Notice that you do not add up all of the percentages. In the last row of the dashboard, you will calculate averages for each column. Take the total from each column and divide it by the number of visits. In this case, we have 10 visits, so our totals are divided by 10. To get the average percentage, use the total time of what you're trying to figure out and divide it by the total cycle time. For example, 106 minutes of MA time divided by 764 total cycle time minutes equals 13.8%, and we rounded it up to 14%. So the average time an MA spent with the patients took 14% of the visit. For this group of patients, the average cycle time was 76 minutes. Time spent in the waiting room was 22 minutes. Time spent with the MA was 11 minutes, with the percentage being 14%. Average wait time in the exam room was 7 minutes. The total wait time was 50 minutes, and the total staff contact time was 26 minutes. The average time with the provider was 8 minutes, and also 10% of the visit. Also notice that the wait time was 65% of the visit, and the staff contact time was 35%. The goal is to have your staff contact time closer to 50% of the visit. The stops and handoffs show a lot of variability between visits. Ideally, the goal is to have as few stops and handoffs as possible while still remaining efficient.
We've now finished describing both tools, the patient flow form and the dashboard. Though it may seem like a lot of detail and number crunching, it's actually a relatively simple method to use when wanting to get a sense of the patient flow at your site. Your dashboard can be shared with your team and used when having brainstorming sessions about what changes you might want to make to improve flow. Ideally, your site should repeat patient flow observations after changes have been implemented to see if any of the variables or indicators have changed or improved at all, but what changes are worth trying. Another CPCA module entitled Improving Clinic Operations, Strategies and Best Practices will take you that next step. It will discuss potential interventions or solutions to clinic flow problems, as well as provide a review of key benchmarks and best practices. We hope you have found this module helpful and that it has helped you feel confident in moving forward with your efforts to make your clinic as efficient as it can be. Thank you so much for joining us today. Goodbye.